Welcome to Cyber Survivor. I'm the host, Dan Dotson, and our guest today is a Chief Executive Officer of Mount Desert Island Hospital, Chrissi Maguire. Welcome to the podcast.
Well, thank you, Dan. I'm honored to be asked to be here and excited to have a conversation about cybersecurity, something CEOs typically don't like to talk about.
I am so grateful that you have agreed to share your story with us so that others can learn from the events that you went through. But before we dive in, just share a little bit about your background, if you would.
Oh, absolutely. So I'm not originally from Maine. So if you are from Maine, you know that you cannot claim that you are a native. So I'm originally from Idaho. I was born in Idaho Falls and raised outside of Sun Valley, Idaho, avid skier. My father was in the military, and so we moved back to the East Coast, and that is how I arrived in Maine. And for the last 35 years, I have been in healthcare and life sciences. My background is in finance, accounting, and economics. And so my history at MDI Hospital is 15 years. I have been here. I was the Chief Financial Officer. I then became the Chief Operating Officer, and I have been honored to serve as the Chief Executive Officer for the last 5 years.
That's great. And we talked about this a little bit last time we were together, but Maine's like one of the only states I haven't been to. So I'm excited to come up and visit you and see that state. So
we're looking forward to you visiting Bar Harbor. It is certainly a diadem of the state.
Absolutely. So cybersecurity and technology in general in healthcare, call it over the last 5 or 10 years, has certainly become more instrumental in the way that we think about providing care in communities. We're heavily relying on technology. You know, obviously you lived through an event, which we'll certainly talk about, but how have you seen technology change the way that we think about running a hospital and coordinating care and those types of things?
I think the interesting piece is we're so enamored by innovation and finding efficiencies that we often have to pause and think about how exciting this new technology is. But what are the impacts for the security of the patient record? And I have been in healthcare long enough to remember trying to read a handwritten medical record saying, I have no idea what this is, to this evolution of moving through electronic health records, and then obviously with the requirement of moving to computerized order entry and moving towards an electronic record. And in the state of Maine, we were one of the first states that introduced a health repository, health information repository. It's called Health InfoNet. It was state mandated that everyone opts into that, and then how we were going to manage that data on top of our own data, and how do we manage it ongoing. And there was a fine line between how do we make sure that the integrity of the health record and the protections around that health record. On paper, you kind of knew where that health record was. You knew who saw it. You knew who was going to have access to it. It was locked up in the doors of our, what we used to call medical records. Now it's called health information management. But now there's so much fluidity in how we advance the record. And there's pressure from our patients to have electronic access to records and be able to protect that. But there's also the nuance of the board's responsibility, and their defined responsibilities for duty to care are to ensure two things. One, that the health records are protected of every patient that we serve, and that there is a high quality medical staff that provides that care. And oftentimes those two things can be in conflict, that with how do we protect that health record, and how do we make sure that those providers who are delivering high quality care are able to navigate these new technologies and find a productive way to care for our patients. And that has just evolved in the last 5 years to 6 years at a rapid rate. And we have to invest in security. And that's the number one thing that most often we think about information technology and information technology services as a consumable that costs us nothing. right? You call the help desk because you can't do this. That is such an important investment that often is lost on the everyday user, on our patients, on our community, and within our board. We spend a significant amount of time educating everyone on the cost of that service and the investments that we have to make to protect not only our patients but our team members, our personnel records, and in general, all that we do in our health environment. And that has been one of our major challenges, and the cost of it has been significant. When we literally look at our capital budget and projects, it would go from maybe 5 to 10% would be IT related. 70% of keeping our network secure and updated is what it costs us each year to fund our capital investments.
Wow. No, that's fascinating that you shared that. I'm very interested to explore this kind of conflict you mentioned around, security and enabling, high quality care. And you said that that's changed over the last number of years. How have you dealt with that conflict, both in the C-suite and at the board level?
I think at first, my opinion on that is our board really just never thought about it. Right? That even though they're our patients, they really weren't thinking about how are you keeping it safe? Do you clearly understand the Health Insurance Portability and Accountability Act, right? Do you understand what HIPAA is and what privacy is and security is? Because it's not just about paper. It is about physical environments and it's about electronic environments. And our providers had to have that reconciling moment as well. We're pushing them to this electronic record, right? Because meaningful use was attractive. It was a very attractive carrot for us to be able to upgrade all of our systems, to be able to provide more continuity of care. And the conflict was for a small rural hospital, and we're a critical access hospital in Bar Harbor, Maine. We have a large primary care system that also is part of our hospital. But how are we going to build that connection between each of these key constituencies and remain true to that duty to care with the board? And I cannot tell you that wasn't, that all the boats were lifted by that tide. It did not happen that easily. It was really investing in key stakeholders, investing in key champions who were understanding the importance of the security, as well as providing them with this new technology that would make their lives easier. Did it happen? No. There's nothing that happened easy. We're talking about pajama documentation. We're talking about provider burnout because these systems actually didn't deliver on our promise to be more efficient. They actually delivered on a promise to be, now you get to access everything 24/7, and we expect you to see more patients. So that conflict, that healthy conflict, is where we have been able to make some advances in listening to our providers, but developing IT steering, which is an internal committee with external community members who help us prioritize, but also raise those boats in the harbor to what our priorities are, bringing our providers into that discussion, bringing our board into that discussion. So everyone now is seeing this conflict, which can be, for me, that's where you put your energy around not the problem, but the solution. And then we can build a system that makes more sense and that it can inspire individuals, and especially our providers, which are fragile in our environment, to feel like there is a quality to the care they're providing and that it isn't simply just chained to a system that makes it more difficult for them. And, then we add multi-factor authentication to it. We add, that you're going to have to go through 4 hoops to do it, and we're going to change your password 20 times. And where do we balance where you start to lose the ability to provide patient care with the ability to secure the record? And there is this fine balance. We call it the will effect here. our electronic security officer. He keeps us all in like, oh, Will must be doing that to us. We can't get into that.
Yeah, that's awesome. So do you think it was worth it? I mean, if you zoom out and think about the digitization of healthcare, you mentioned physician burnout, all these security controls, the costs. I mean, do you think the digitization of healthcare at the macro level has delivered on its promise of better care, faster care, more coordinated care? I mean, was it worth it at the industry level, do you think?
I think it's getting there. I don't think we're there. And I will tell you, I think in the last 2.5 years, I've seen some improvements. We a little bit of history, Dan, and you can carve this out if it's not interesting to your listeners. When I talked about that original move to electronic health records, we had 7 EMRs here because you couldn't rural small hospitals couldn't afford a full Epic or a Cerner system because you couldn't invest $25 million. There's just no way we could do that. So as these larger companies started to see, hey, there's a market for these smaller people, how can we do that? There was some advantages to that. But when you were talking about, we had a separate EMR for our emergency department. We had a separate EMR for our health centers. We had a separate EMR for the billing center. We had a separate EMR for the inpatient unit. And nobody was talking. That's where that digitization failed miserably, because the number one thing that I hear most about is medication reconciliation. You can imagine going into an emergency room and your emergency providers can't see your outpatient record to know if that medication is correct or if you're even allergic to it. And that was really the premise of where we moved to this opportunity to go to one electronic health record. And was that nirvana? No, it wasn't. We did it at the worst possible time. Hindsight's 2020. We did it right at the end of COVID when it was March 7th of 2022, where everybody decided to exit the workforce. So that was where it was bumpy. But today, I listened to this medical staff say, yeah, I saw that how you treated that patient in the ED. I saw him in clinic the next day. I had the information. It was seamless transitions of care. It is getting to what we had hoped to deliver on that promise. And that internal to our MDI health system, our providers and our patients are having seamless transitions and getting that digitization, and it's meaningful. We're still not reaching that global, that when you talk about that national effort to get to a continuity of care, that is not there, because we're still market share driven and we're a capitalistic society, and we all appreciate that. But the patients, unless we get to a national database repository where seamless transitions and information can happen, the patients still suffer in that gaping hole of, I went to this hospital and I had this procedure done, and the test results aren't back into our system. Those things still exist, and those are some of the most dangerous things for security interest, right? Multiple interfaces. How do you get the data back? How do you protect the data? That's where we lock ourselves down, and we have to think, how do we manage this system so we're not exposed to a cyber threat or attack, and be able to still provide the care we need outside into our system.
No, I appreciate you sharing that. I think it's always important to kind of set context of how IT's evolved over time as we've moved from multiple systems to, fewer systems. A lot of folks don't understand that even though you have a core EHR, there's still, tens of hundreds of systems around that EHR that help us coordinate and deliver care every day. So it's a very complex technical ecosystem still today for that care coordination, as you mentioned.
And I would argue the point, Dan, I'd be interested to hear your thoughts on this, is I also think there's a misnomer between these new electronic health records, if that obviously is the focus today, is it's not an IT system, right? It's a clinical system that has components of information technology, but often we say, "Oh, well, IT needs to manage that." It really, what we learned is IT is that wraparound warm fuzzy, but clinical informatics people and experts are now, that was a big change for us, right? Like we had to hire clinical informatics people to manage this system that we now have, and we use Oracle Community, Cerner Community Works to help drive this system, because IT, that's not their job. Their job is to make sure that the network can support it, and that is the biggest evolution. And it was a very big key learning for our organization.
Yeah, I think that was a common learning across the industry, quite frankly, to your point. And I think that, these clinical systems, infused with the rev cycle systems, which is important for the kind of entire coordination of the patient experience, have come together. But it's like the ERP of our system, right? You have a manufacturing company that's using technology to manufacture something. There's experts within that manufacturing facility that have to work hand in glove with the technologists to make sure that they can produce effective materials out of the manufacturing. It's the same thing in these clinical environments. We have to have experts that understand the delivery of care, understand that coordination. Clinical informatics, as you mentioned, is how we kind of label that as an industry, to work with some of the technology experts to make sure that we're driving the results that we want, which is that care coordination, safer, better, higher quality care. And certainly the market's evolved and learned a lot from that. We often think about, in the backs of meaningful use and the High Tech Act and all those types of things, cyber wasn't a huge conversation as part of that, right? And so we took a legacy industry that was on paper or disparate systems, as you described, tried to centralize it to help more with the coordination of care. But oftentimes we didn't think about what the adversaries were going to do with that, the amount of data that we were going to produce, how these systems were going to talk and be integrated. And we entered into this new dynamic where we took somewhat sophisticated or more complex systems. We put it on sometimes legacy in an environment with legacy applications, on a legacy infrastructure, and it created a hotbed of information that the adversaries wanted to come after.
Fertile ground, right? Fertile ground. And I think one of the things that inspired us to move to a different, one single source of truth is what we called it, right? The patient source of truth was we did have so much exposure, right? We were hosting the system on site, on-prem. That was a problem. It just further exposed us. And, to go and visit the big, huge data and cloud-based technology was very appealing to us, right? That it was one more thing that would help us be able to mitigate exposure and risk to our ongoing system. So that was really part of that decision-making process. Because when we flew to St. Louis, we flew our security team, our electronic security team, our information technology team with us to say, what do you think? Right? We love this, but is this going to reduce our risk and exposure to a potential cyber attack?
Absolutely. No, that's absolutely right. I think lots of people have thought through that as well. Let's pivot a little bit and talk about before you had a cyber incident. Mm-hmm. What was the cybersecurity conversation like in the C-suite and in the board level prior to having an event? What was that like?
We actually had a wonderful opportunity with what we had formed and were a member of, which was called the Main Rural Health Collaborative. It was 5 independent rural hospitals in Maine. And our goal was really to look at back office efficiencies. Where could we network? Where could we share information? And part of that, there was an IT group, there was a revenue cycle group, there was a clinical group. And part of the IT group really wanted to focus on, we should be looking at improving cybersecurity. We should be looking at risk assessments, but cyber insurance. So we had this little nugget in our general liability, and here's your little piece of the pie, and I think it was maybe $75,000 worth of coverage, right? And from this group, it just started to really unpack for us the ongoing issues that are happening with cyber attacks in healthcare. And one of our hospitals in Maine actually had a cyber event very early on. I mean, I'm going to say eight years ago, maybe 10 at this point, because COVID, I've lost track of time. I'm not sure when that was. But what had happened is someone had brought a USB into their hospital, plugged it in, and malware spread throughout and shut down everything. And it was on our minds about, wow, let's get rid of these things. How do we control that? And we were just at that inflection point of, we need to build up our resources here. We need to look at improved cybersecurity. The American Hospital Association was starting to make this a real initiative, a strategic initiative. So we were starting to gain more conversation about the importance of cybersecurity. And we invested in a very, very robust cyber security insurance as this collaborative, right? We got $5 million of coverage. It was really healthy coverage for us. And with that, though, came requirements. You're going to have to do this. You're going to have to do this. And it just continued to help us unpack what we needed to do to be much more acutely aware of what our exposure risk could be. And I will tell you what, my team was informing me all the time. The unique thing at our organization, IT reported to me as a CFO, I kept him as a COO, and I've kept him as a CEO. And so the direct conduit, good, bad, or indifferent, is I know what's going on in this organization and what the needs are and what our exposures are. And that can help drive change fairly quickly and without a whole lot of barriers when we're dealing with potential risk as well. But it also was, how are we going to invest in improving this? And where are we going to find those capital dollars to do that? And it was informing the board. One event can take us down. And not only with our reputation, but how are our patients going to be cared for? And where are they going to go? And we talk about our downtime procedures, but what are we going to do afterwards? And that work started from that work we did with the Maine Rural Health Collaborative, and it parlayed into, what are the resources now? How do we budget for these resources, and what does that look like? And where do we get the experts? And where do we invest in professional growth and training? And how do we continue to invest in that ever-changing dynamic world that we have committed to? And that was a board-level discussion. It went up. That's where the IT steering committee was formed. Let's prioritize our risk stratification. How do we align that with our projects? How do we align it with the resources that we need? And when I speak about resources, it's time, people, and money. And how do we inform the board? And how do we get the board cyber training, security training? And so our board was very amenable to this. They were like, yeah, we want to hear about it. We want to know about it. It's our responsibility to make sure those records are secure. And that's what started our preparation before our event, right? We're cyber focused. I was super focused on that electronic health record, right? Making sure the network's available, making sure people can get access to our health, the records, and that there's fluidity in their day and their workflows, etc. But with that, as you said, we were not looking at all of the risk associated with that. I would say I'm pretty sure my IT team was like, this group is driving us nuts. This group is driving us nuts. We're exposed, and really trying to inform where our exposure was.
Yeah, I want to compliment you on something. We don't often hear CEOs having direct responsibility, or direct line responsibility, I should say, for IT into them as a reporting structure, which is kind of an interesting concept because, we've talked a lot about how, IT is so instrumental in how we deliver and coordinate care ultimately to our patients. And so my compliments for you doing that. I think that that's really important and something that others might learn from as well, because it's such a critical element, to delivering care, but also from a risk perspective as we think about cybersecurity.
And I think, Dan, also you have to think about in that structure is I also can put pressure on that team to think differently about the care coordination and our patient needs, right? How do we innovate? Right? Where's this technology? Can we go with it? Right? Artificial intelligence. How can we look at all of those risks, but take out and glean out what's really going to advance patient care and productivity for our providers and our clinical teams? Every single person in this organization touches a patient.
That's right. Absolutely. No. Yeah, we're all patients. We're all in this together for sure. And I think that it's really interesting because I often hear CIOs and CISOs still today trying to fight for the proverbial seat at the table, right? And they often, hear of an initiative after it's well down the road, and they're kind of the last people to know. And part of that has to do with just structure, to your point, and being able to share the vision and influence the way that they're thinking about things, making sure that they're coordinated with their clinical teams. And so structure-wise, I think that's fantastic that you're doing that. Let's move to the proverbial bad day. So tell me about how you first heard about when you guys had a security incident, and what was that like for you?
May 4th, that day?
Yeah. May the 4th be with you, right?
Yeah, may the 4th be with me. That we needed to make sure that the team could do the work they needed to do to protect our systems, and that we would check in and develop the communication plan, and we would just set up our incident response plan. And that's what we had done. And we had systematically put these policies and procedures in place. So, and we actually were doing some tabletops to practice them. And so that is where we started with. We just didn't know what we didn't know at that time. We enabled our partners, that came in to help us do this work with us and start to mitigate that exposure to our systems. What we found is we had a vendor that was a vendor partner who we were giving access into our system to do work within our platform that was not adhering to the security protocols for terminating employees that had left their organization. And those those system access points were exposed, vulnerable, and they were able to get in and reset a password and get access in. And they used that portal to be able to go through our networks, file folders. So we have an internal network file folder system, and that's where they started to go through and look at and start to extract data. And that was a scary point. Like, what data did they get? Did they get into the electronic health record? Are they going? Is there kind of malware or ransomware that is in there that is going to shut the system down? And I reflect back on that, that bunker where we were in St. Louis and that cloud-based security system. And when Will Houston, our security officer said, it's a cloud-based system, they can't get at that. I'm like, oh my goodness, right? They're not going to take us down on this. So they did not get there. Everything we had invested with our partners like you with Fortinet and Fortified, it's all part of what we were able to do, that the bells, the whistles, the stopgaps started to work. And we were able to quarantine and start to stop that advanced attack into our system and begin then a mitigation strategy.
Yeah, it's always a challenge if you haven't lived through one of these events, because you make all these investments and then you start questioning the costs. Every dollar that we spend in IT or in cyber is a dollar away from the bedside. We operate in a low margin environment, but when you're faced with the situation that you're faced with and what you invested in begins to work and pay dividends and allow for you to continue to operate in some capacity, although a different capacity than normal, it certainly makes the day a little bit easier to navigate through. Ultimately, how did you see care impacted during this period of time?
Well, I think the biggest thing was we shut down all those network folders. And it was like what you didn't know, right? Like who was accessing it, who was using it, where were they going to get the data? And there was impact to patient care because some of those data folders had referral information. That is where they would store some health information management information. So you couldn't get at those folders. You couldn't get at those folders for human resources. There was, that's where there were data portals. It started to have some impact as how could we prop these folders up after we triage them to see if that one was clear or if anyone had been in that and open those back up. What they actually did was make a copy of the entire structure and put it into, I always call it the sandbox, a quarantine box, right? The sandbox to be able to work through that. And then they would start to open up the folders back in through a different pathway. So the hardest thing was people to relearn the pathway of how to get to and navigate back to their folders. But we're still working through this today, Dan, we have to be better stewards of that data. It's antiquated, it's old, it's going to, if it hasn't been opened and it isn't in a specific origination folder, which has like the deeds of the hospital, right, there's going to have to be some expunging going on because this is exposure. And we were exposed. We have class action suit. We went through, as I told you before, I learned terms that I never thought I would learn in this process. But that was, there was some patient impact, but it was fairly minimal. We focused and prioritized on and when I talk about incident command, every single leader in this organization was at the table, either virtually or in person, and we were talking about what was happening. Our comms team, our communication team, was doing a daily briefing every single day. We were high throughput at this point, right? Because I was truly keeping two resources propped up and working almost. I'm going to say 100 hours without sleep. Will and Christina just continued to work and navigate how to keep the health record propped up, reduce exposure, and get access to those high priority folders as soon as possible. And again, we brought in our partners because we needed partners. You couldn't do this with a small team, and we have a relatively small team. But those two individuals were the best investment I made in really saying, these aren't just nice to haves, these are must have resources. And we continue to say, you go and be creative and think about the training you need and the exposure you need to think about how to protect our system in a very broad lens and a very tight aperture. And that's how we keep supporting them daily, is keep training, keep learning, and do what you must do.
Absolutely. Take us onto the floors of the hospital. I mean, how was the clinical staff impacted? What were they thinking? Was there certainly an increased level of anxiety? I can imagine, as that coordination might be a bit different in the midst of this event. What was that like?
They were very concerned because we did take Cerner offline. We're like, we're going to go to downtime procedures. We've got to do this. We've got to do some. And everyone was like, oh, my gosh. We were hearing about these events that were happening and systems were going down for months. Patients weren't we didn't know health records. We didn't know medications. Doctors were panicking, and we were doing a whole bunch of what if scenarios through this process, convening our medical staff. We convened the medical executive committee to talk about this process, how we're going to handle it, what the next steps will be, keeping our nursing staff and our patients. We had to set up a whole phone bank for the calls we were getting, because our patients were concerned about what was their data exposed and what we were going to do about it. The media had wind of it. So hands-on patient care. How do we talk about this? What does the scripting look like? And how do we keep people calm? We don't want them up here. We don't want them down here. But we need to have a level of confidence that our patients do not believe that we cannot care for them. And that was our number one priority. We were rounding on our patient areas. We were going out to each of our clinics because we have 9 clinics that we have to take care of as well to make sure that they weren't impacted. And our clinics were impacted because they typically were using those shared network folders to gain information about patient referrals and things to see about where that patient stood or validate some type of demographic information. And the other thing is we shut down their ability to go into the legacy systems. So here we are in this new system, and all the legacy systems we shut down because we weren't sure if they had been impacted, where all that data repository information, you think about, I needed to see a test result from something 5 years ago, can't get it yet. We can't release it. So there was impact on patient care, but it could have been much more worse than it was for us.
Did you have to cancel any appointments or delay any care, or were you able to just continue to serve the patients just maybe a little bit slower than normal? What did that look like from the patient's perspective?
Fortunately, the patients were not impacted with the delay in care that most organizations have experienced. We were able to, there may have been a little bit of inconvenience, but there was no significant delay in care for our patients.
And do you attribute that to some of the prior investments you made, the response, the communication, the grit of the team? Because you're right, Chrissi, we read all the time and have clients that experience all the time, we're canceling appointments, we're deferring patients, we're deferring ambulances, that happens a lot. Why do you think that you were able to survive that?
I can't say it was one versus the other. I think it was obviously the major investments we made. And I think one of the major investments was bringing a electronic security officer into our organization to tell us really where our exposures were and what investments we need to make strategically. And I often say to Will, tell me what my 1 year, my 3 year, my 5 year are, because I need to look at that planning and it doesn't have to be as precise as, but we can't take 100% of our capital dollars to this. So we need to spread it out and figure out how we advance it. And really bringing that level of expertise into the organization and a trusted individual that everyone just trusts the knowledge has been incredibly impactful on helping us continue to secure our systems. But that was part of that investment. The infrastructure, hardware investments, the penetration investments, the additional firewall investments, all of that was here. This is what we're going to need this year, and this is what we're going to need next year. So we feel like we're building, if you will, our kingdom and our fiefdom of security. But it was the grit of those two individuals who Christina identified something looked suspicious, noticed the lateral movement, that person's credentials should not be moving this way, shut it down, and then able to do the investigation. But it comes from, I always say, this culture, this organization is amazing. These people are so invested in our promise to deliver on our mission and deliver on our promise to care that it's truly amazing, the work that was done to mitigate our further exposure.
No, that's great, and you're right. I think those investments certainly were paid dividends, so to speak, during that event. As you now think about conversations around cybersecurity post-event, how have you thought about things differently? How's the C-suite or the board thought about things differently, having survived that event with certainly some disruption, but not a huge impact to patient care? How have those conversations changed post-event?
It's interesting, not only the C-suite and the board, but even even my leadership team, no one questions an investment in IT security. It's like, okay, we need to do that. Absolutely. We all go to what we call no before jail because we get tripped up with some type of planned phishing scheme, and I'm notified if somebody does who it is. So I'm like, oh, I see you have to do some education. But those investments are board. Our board receives cybersecurity training each year. That training is really embraced by our board. The dialogue, it's typically 2 hours of cyber training is pretty substantial for volunteer community boards. And this past March, we weren't leaving. They asked a significant amount of questions, and it's been embraced. I think there's always a hesitancy of where's our, I hate to say it, it's not if, it's when. When is there a vulnerability that we haven't patched or found that's going to hurt us? A partner hospital in Bangor right now is going through a cyber attack, and it's painful. And I'm texting him saying, "We're here for you, right? We know what it takes to do this." We just last week got our notice after 2 years that the OCR accepted our report. The Office of Civil Rights has to approve all of our mitigation strategies and communication that we did and the protections we had to do with our patients. That's a heavy lift, right? You have your security team working on physical protections, but then they also have to do all of these reporting requirements and ongoing mitigation strategies. It was resource intensive, and I think some of it was we made some decisions because we knew our community and we knew our patients and we knew our team members, right? Like. Legal teams don't talk about it. I'm like, I have to tell my team what's going on. I have to tell my board what's going on. This is not how we conduct business to say, oh, by the way, we may have exposed your data. Our team needs to know what's going on. They know something happened. So if we have potentially exposed their data, I want them to know, and I want them to know we're going to give them the proper reporting tools and protections in place to do that. And we had to negotiate that oftentimes about what we felt was the right time and cadence for communication.
Yeah, that's certainly a dynamic that you have to think through in these events is what's the right level of information to the right people at the right time. You mentioned earlier that, class action lawsuits are part of this, cyber journey that everybody's on now if you go through an event. So you have to be extra cautious about sharing information at the right time. And that's certainly another complexity that people must think through when they go through these events.
Yeah. And again, I feel that we have grace upon us because we were able to mitigate the exposure, but that was through these investments, and that was through training and growth and awareness that we have decided was aligned with our mission and our board's responsibility and ours as leaders of this organization and stewards of healthcare, to be able to ensure that access to services remain. And that was part of what we were able to accomplish.
That's great. What recommendations do you have for other CEOs as they think about where their organization may be in their investment in cybersecurity? Any things that you've learned along the way or recommendations that you would have for your peers?
I think the most important thing is really start to immerse yourself in what is going on in the healthcare environment and how the appetite for our data is so sought after by threat actors and by nefarious individuals throughout the world, and that it is not going to be, and that isn't going to end at any point in time. You need to understand, first of all, why people or threat actors want your data. And what are you doing to ask those specific questions with your teams about how are we protecting it? How should I invest more information and awareness throughout the organization, but also with your board? The board has to understand their responsibility in this. And I shared that with our board. There's a white paper. The American Hospital Association wrote a trustees paper on it, and that was an eye-opening experience for our board to really hear that this is actually your responsibility. And then say, well, it's her responsibility. And so how do we ensure that? But those things are really cyber insurance. If you do nothing at all, get cyber insurance. Whatever you can possibly afford, because you're going to need it at some point. Invest in great collaborations and partnerships with known entities that have a reputation for being a partner and making sure that you're aware of what's going on and how to improve, and invest in penetration test, invest in making sure that your firewalls are secure, invest in white hackers, do the work, because if you want to maintain a sustainable organization and not impact patient care, you have to do that work early, and you have to understand that work, and you have to be willing to be a student of the work, because I'm certainly not an expert, but I'm willing to be a student and willing to go and invest time in understanding it more.
That is great advice. There is certainly so much happening and always something to learn in cybersecurity. So I appreciate you coming on and sharing your story. I have certainly learned a lot. I'm sure our audience will as well. Any closing comments that you want to make before we wrap up?
No, I thank you. The only thing I say is, hopefully you don't ever have to learn who a threat actor negotiator is. That's my closing comment, because that means something bad has happened to you.
I hope that is true as well for everybody. Thank you so much for your time, Chrissi. This is Dan Dotson, and this is Cyber Survivor.